This is chapter 30, musculoskeletal trauma. So along with our bones, like you see with Mr. Skeleton right there, we also have soft tissue injuries that can accompany these other injuries. So muscles can be torn, cartilage can be damaged, tendons can be torn, and so can ligaments. So tendons hold muscle to bone, ligaments hold bone to bone, and cartilage is the padding between our joints. And various injuries to bones and joints. So fractures are the most common thing we see out there. That means the bone is broken. There's open versus closed. A closed fracture means the skin that's overlying the fracture is intact. There's no puncture wound or laceration created by the fracture. An open wound or a compound fracture means that the bone is now protruding through the skin and it's broken the seal essentially. So any bacteria that's on the skin or out around in the outside world can get into now this wound and cause a bacterial infection to the bone and the surrounding tissue. So when you have an opened fracture, it's a little more complicated because at the hospital they have to open up that wound, they have to clean it out, they have to debride it and give you antibiotics, and then of course then reset your bone back into its normal position. So it's a little more complicated than a closed a closed fracture. And of course, people who have osteoporosis, elderly females primarily, they're more prone to fractures because their bones are so fragile from their medical condition. All different kinds of fractures. This is someone's humerus, it looks like. An obvious fracture to that. It had to be pinned together, it looks like, due to the severity of the fracture. We have strains and sprains. So strains are a pulled tendon, and a sprain would be a pulled ligament, basically. So not that we're going to really be able to tell in the field. They're very similar presentations. They're going to be swelling and pain at the site of the sprain or the strain. Dislocations are fairly obvious in the sense that you're going to see a displacement of the joint. The joint's going to look like it's out of place, which in fact it actually is. The bone's not broken usually. It's that the joint has been dislocated, and because of the muscle groups around it become they get tonic contractions. They get locked up essentially. The bone can't go back into place very easily, and the doctor has to reduce this, usually at the hospital. So there are some critical fractures, and the two that we encounter is the femur fracture and the pelvic fracture, and it's solely because of the fact that there's massive bleeding in both of these sites. This is an open fracture to the femur, the bone's protruding through. You can see how gross it is just looking at it. But they could have ruptured a large artery in their upper leg and could be bleeding profusely, either internally or externally. Same thing with the pelvis. They could have fractured their pelvis, and they could have lacerated a large artery or vein in their pelvic girdle, and lots of blood loss in that process. So general rules of splinting. Purpose of all this is when you splint someone's limb, and we splint people's limbs, and in fact, in the case of spinal motion restriction, placing someone on a spine board is basically just one big splint. We're splinting their entire body essentially. So we can splint an arm, a leg, their neck, or their entire body, depending on the circumstances. But ultimately, the purpose of this is to reduce the chance of further injury, to reduce their pain and discomfort from the injury, and to minimize any complications. So we got to do it right and do it safely. So what you want to do is anytime you apply a splint, whether it's an arm splint, a leg splint, or an entire spine board, you want to check pulse, motor, and sensation before and after you splint to make sure that there's improvement, you haven't lost their pulse, motor, and sensation. If you're splinting a joint, meaning that they have dislocation to their elbow, say, you want to stabilize the bone below that joint and above that joint. So your splint would go from about the area of their knuckles all the way back and up to just about the top of their arm. You're going to splint the entire arm. You're trying to use the upper and lower bones to stabilize that now dislocated elbow. If they have a broken bone, like a forearm, you then want to stabilize the joints above and below the fracture. So you're going to stabilize the wrist joint and the elbow joint with a splint to maintain some kind of integrity so that that doesn't move around when you're transporting the patient. Remove their clothing in the area on the limb, take the jewelry off due to possible swelling. And then if you do have someone with an open fracture and there is a bone sticking through, we would never intentionally try to replace that protruding bone. But there is one exception, and that is if there's poor pulse motor and sensation distal to that fracture, you can get on the radio and get a base hospital order to reduce the fracture. So the doctor or the nurse on the radio will give you an order to pull on that limb, lengthen that limb back out, and draw that bone back under the skin, because ultimately at the hospital they're going to cut that limb open, they're going to debride the area, pin the bone together, and have this person on antibiotics. So it's not that big of a deal, but we don't do this without a doctor's order, essentially. And then of course, if the patient has critical life-threatening injuries and they got a broken arm, the broken arm is a non-life-threatening secondary injury, and that injury we would treat en route to the hospital. So we put the person on a spine board, we start transporting the patient to the hospital, we treat all the life-threatening things first, and then if we had time, we would splint the arm, splint the leg, cover the abrasions. Those are all non-life-threatening secondary injuries that we only treat when we have time and en route to the hospital. So there's all different kinds of splints. We'll show you a bunch of them in the lab. You can make them up with blankets and pillows. We have manufactured splints like the SAM splint, the traction splint, the pelvic stabilizer device. It's as long as it's rigid enough and can immobilize whatever you're trying to immobilize, it works, as long as you make sure that it doesn't cause any harm. Now, when it comes to improvised splints, this is a blanket splint for somebody. They're okay. You notice the toes are exposed, so they can still check pulse motor and sensation. You can use cardboard. I've even used 2x4s before to splint people's limbs when I had nothing else to use. So it works pretty well. Make sure it's padded. Make sure there's no sharp edges on it that can cut the patient or cause abrasions to the patient. And make sure it's long enough to immobilize the area you need to immobilize. So if you had a fractured lower leg, you need to immobilize the foot, the ankle, and the knee. So that splint would have to go above the knee. So it would have to go from the foot all the way to about mid-shaft of the upper leg. It's a pretty long splint. So if you find a piece of 2x4 or a piece of plywood or something, if you pad it, that would work. Luckily, we carry splints that long on the ambulance. So hazards of splinting incorrectly. If you have to realize, and I'm sure some of you have had broken arms and broken legs before, you probably noticed that after you went to the hospital and they x-rayed you and the doctor set your bone back in its proper place, they put you in a partial splint. So it's hard on the bottom and soft on the top. That allows for swelling to occur. Over the first 24 hours of a fracture, the arm can swell considerably. So we want to put a splint on that's kind of similar, that kind of takes into account a possible swelling process going on during the hospital. So we want a nice rigid splint to hold that limb in place, but we don't want to make it too compact because we want room for expansion there. So make sure it's not too tight, make sure it's not too loose as well. And of course, if you're delaying, if you got a guy with a head wound or a head injury, and you're trying to tape up his ankle at scene, well, you're just wasting his life and your time. And then if they have a broken limb and it's pretty stable and you don't really need to splint it right now, just the process of moving it around, trying to splint it, can actually aggravate that particular injury. So sometimes your best battle is just to leave it exactly as you found it. What I find with this is people who have broken arms and broken wrists, when you get there, more than likely they're going to be holding their good hand, they're going to be holding that that bad limb with their good arm, and they're going to be holding it to their chest. It's called self-splinting. So, if the person doesn't want you to move that arm, doesn't want you to splint that arm, and they're doing a good job of self-splinting with their own hand, why move it around? You could just take them to the hospital like that, and at the hospital they can give them medications, and they can give them pain medications and do the x-rays and all that in a more stable environment. When it comes to splinting long bone injuries, this is the upper extremity and the lower extremities. Signs and symptoms can be obvious deformity, pain, swelling, lack of sensation, means it's called paresthesia. It's kind of a numbness or a numbness or some type of tingling. They can get distal to the injury. They can also have a loss of pulse motor and sensation as well. Sometimes it's really obvious the arm is broken or the leg is broken, and sometimes it's just swollen and tender to the touch. And it's really hard to tell, especially with ankles. It's hard to tell whether it's a sprain, a strain, or a fracture. You treat them all the same anyway. You're going to splint them, elevate them, and ice them. Check pulse motor and sensation, and then you're going to mobilize the joints above and below the fracture. So in the case of a lower leg injury, you'd want to stabilize the ankle, the foot, and the knee. So you need, again, a fairly long splint. If it's an upper limb and you have a forearm fracture, you want to do the wrist and the hand, and then all the way back and the elbow, and then up, partially up to the biceps. You want to have a pretty good stabilization point to stabilize that forearm fracture. Just depends on where the fracture might be. Now, again, with joint injuries, because the bones are intact, meaning they're not fractured in any way, the bones are stable, the only problem is that the joint has been dislocated. We use those stable bones to stabilize the joint by stabilizing those two bones above and below the dislocation, using them as an anchor point to maintain stabilization. Our biggest concern when it comes to joint injuries is, even though the bone is not fractured, because it's been displaced from the socket, the nerve endings and the blood vessels that travel in that joint can be damaged by any movement. So we try not to move a joint injury at all if we can help it. Again, if there is poor pulse motor and sensation, if you're concerned this person has reduced blood flow to his extremity due to the dislocation or the fracture, their hands are cold to the touch, you cannot feel a radial pulse, they can't feel their hand's numb, you can call the base hospital and get an order to reduce that dislocation by doing the same thing, pulling unilateral traction until the bone realigns, and then you would splint it in that position. Obviously, in both cases, whether it's a joint injury or a fracture, it's going to hurt a lot. So you really have to have a strong reason to do this rather than waiting to get to the hospital and have the doctor give them pain medications before this happens. Femur fractures. So what we're talking about right now is a mid-shaft, isolated mid-shaft femur fracture. The femur is the strongest bone of the body, and when it does fracture, the weak point is right in the middle, right in the center, and that's where it's probably going to snap. Because of all the massive muscles around and all the arteries around and inside the femur, you can get a lot of bleeding into the upper leg, as well as a lot of tonic contractions, which causes the leg to shorten and the bleeding to cause this area to swell, the upper leg essentially. So you see this shortening of the limb, you see the swelling to the thigh in proportion to their non-affected upper leg. And you look at the mechanism of injury, fall off a ladder or car accident, it takes quite a bit of force to fracture a femur. If you do think this might be a femur fracture due to the signs and symptoms, it's an isolated mid-shaft femur fracture. You can use a traction splint. Now, there's a Sager traction splint and there's a hair traction splint. Depends on what your agency wants you to use. You might have both. You might have one or the other. The idea behind these things is they anchor to the pelvic girdle and they anchor down to the ankle of the injured leg. And there's a traction that pulls that limb back out to its normal length. So the pelvis has to be stable, and so does the ankle and lower leg of this person. So they cannot have any other injuries to that side of their body. They cannot have a pelvic fracture. They cannot have a knee injury or a lower leg injury or even an ankle injury because it's no longer stable enough to be used as anchor points. So traction splints are only for isolated mid-shaft femur fractures. They cannot have any other injury, fracture to that limb that compromises the stability of that limb, including the pelvis. And we'll show you in the lab how to apply these and proper methods and purpose and all that. But again, same thing. It is a splint, basically. So you're going to do pulse motor and sensation. You'll then apply the splint as appropriate. And then once it's applied, you'll check PMS again. Pelvic fractures, if the person does have a pelvic fracture, there's various ways of treating this. You can use a pelvic sling, these manufactured ones. They're very, very expensive. We usually don't have them on the ambulances, so we wind up using blankets, like you see in this picture right here. The pneumatic anti-shock garment, even though it's still taught usually, they haven't been in the field for years and years and years, but essentially it's a pair of pants you can inflate. It's the only way I can describe it. And you could use it to stabilize the pelvis, though you're probably never going to see one in the field ever again. More than likely, you're going to wind up using some kind of blanket wrap, or if your company has a lot of money or your agency has a lot of money, they might have a pelvic sling or some type of pelvic stabilization device. And the idea here is you're squeezing the pelvis together, you're stabilizing the broken bones, and you're actually controlling the bleeding by this pressure you're applying to the pelvis. Ultimately on this, for the protocol quiz coming up, you should read up on S141 about pain management, and on S139 you should read up on fractures and dislocations, your BLS level treatment for this, and then we're done.